you, Helga. Thank you, Bjorg, and all the organizers for this wonderful session. I'm going to talk about the work that we're doing globally and then also at the country level. That's how WHO works, mostly informed by what's happening in the country. Human rights is at the heart of Sustainable Development Goals and our mandate for the 2030 Agenda. We will not be able to deliver without strong attention to human rights-based approaches. This requires that we step out of our comfort zone. It requires that we do things a little bit differently. It means that we work with other sectors. What we know from the Sustainable Development Goals and what's guiding us is something that's a bit different from the MDGs, which is that we're looking at inequalities not just across countries, but also within countries. That is in goal number 10. So data disaggregation in goal number 17 is central, is critical to what we do. So let me give you an example. In the MDGs, we looked at cross-country disparities, and for the past 15 years, we've reduced infant mortality and maternal mortality quite dramatically from largely the good work of many people in this room. But more must be done along this path, but we also need to focus on these in-country disparities. For example, skilled birth attendants, there's an 80% disparity between the richest and the poorest within countries worldwide. And that's taken from a book, The State of Inequality, in the back. Please help yourself. There's many more, much more similar information. So goal number 16 tells us to be accountable, transparent, to use participation in governance, and then finally goal 5 is about gender equality. So let me talk a little bit about what that means for WHO. WHO uses an integrated framework. We don't look at human rights in isolation from equity work, from our gender work, and social determinants of health. It is, we believe, although we come from different histories, different language, it's together where the solutions lie to these intractable problems. So for a reminder of some people, the key principles that we're working on in human rights is the access barriers around availability, accessibility, acceptability, and quality, also participation, non-discrimination, and transparency. So what does that mean operationally on the ground for us? Referring to what the director of Norad, John Lomé, excuse my mispronunciation, is that there's power in figures. So we look towards social epidemiology. We look towards monitoring health inequalities, and this is only possible when we disaggregate their data. Averages does not give us enough. So globally, if we look at the global level, we now have in reproductive, maternal, neonatal, and child health, 94 countries that are disaggregating data regularly and that we can track over time. We need many more countries to be doing this. We also need more programs like non-communicable diseases, neglected tropical diseases, and TB, et cetera. So at the country level, we need countries to collect, analyze, interpret, and report their data on disaggregated data so that we can make management decisions, programmatic health system decisions. So we don't stop there. At the country level, programmatically, we use, yes? 2 minutes. 2 minutes left? Wow, that's a lot. We identify those excluded groups through this analysis. We look at what economists refer to supply and demand side barriers, and we also look at the facilitating factors, many beyond the health system, again, working with other sectors, enrolling them into our health project. And then, of course, civil society, and with the generous support from Norad, we've been able to test this in many countries. You'll be able to hear about this later this afternoon. Again, at the country level measurement, while at the globally, we look at health inequality monitoring. At the country level, we are starting to use the framework that Flavia described this morning, looking across a spectrum. Please look at page 17 at the individual, structural, programmatic, and societal levels. Thank you.